Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Very excited to be sitting here today with a fascinating human being and a real mover and shaker in the value-based care space. This is Gail Zahtz. And Gail, I came across recently and was surprised that I haven't come across you before because Gail has done speaking engagements and has been involved in value-based care from really early on, having some real interesting kind of realizations about value-based care before it was really a thing. Obviously, today it's becoming more and more of a buzzword and slowly gaining some good traction and becoming a movement. But Gail has been there, I think, really from day one. Really some fascinating stories. So I'm excited to hear more details on. Gail, thank you so much for sitting with us today.
Thanks for having me. I'm really excited. An hour to get to talk nothing but value-based care. Amazing.
It's a dream, right? So tell us, let's start with where you grew up and at what point. I know for you it's a little bit different because you're not a doctor per se, and so there was something in your life that made you get involved in healthcare. So where'd you grow up, and what was your general life, and then what happened at that pivotal moment?
Yeah, it's so interesting because if I look at my career, it looks like it was a very planned trajectory, But to your point, we started working on this before there were hashtags, before the ACA, before there was a format. So grew up in Philadelphia, went to school in New York. I was very, very early on involved with sort of social justice. And so healthcare, even at a young age, was a natural connector to that. I mean, when I was 15, we did this whole big camp for economically underprivileged children and brought them in, and so it was this was in Philly. Greater Philadelphia Federation of Settlements was our partner. Yeah. So, sort of very early, young on, looked at what is now groundbreaking many years later, that it was all one, that we couldn't separate, this is going to the doctor versus this is I'm hungry. Mm-hmm. But my experience was, I went into healthcare because I was just trying to help solve major social issues. And let's be honest, then become, get some profit out of it also, because I chose not to go into nonprofit. And my first two startups were in my 20s. My second funded one was also in my 20s and was in this. So the first one was a cause-related marketing, which is sort of like when you connect a cause to your. And from that, I did this employment resources conference for the Department of Labor that dealt with employing people with disabilities. And one of my clients came to me one day, and this is when money was falling from the sky. I mean, this is 1999. Amazon, nobody was like, Amazon, we don't get it. Why are they selling just books? There's Borders, and there was this company, Value America, that everybody thought was going to be what Amazon is today. And it was what would you do with the money? Value America, they bankrupt. Yeah, they did not make it.
They Kodak.
I've been at many of these rise and falls, right? Watching. It's like the Forrest Gump of healthcare, I think. And one of my clients was like, well, what would you do with money? I'm like, how much? And I just sat down there with a napkin and wrote it out. And the next day we walked to the bank. He deposited $800,000 on what ended up being $1.8 million. I thought money just fell from the sky, And it was at that kind of intersection, bricks and clicks, publishing, as well as online. This is when websites were $1 million, and to get internet required 2 T1 lines going into the office. And it was really focused on this sort of workplace health, right? Because I said people are at work all day long. And so why aren't we ever talking about how they can improve their lives with the work they do? And so this kind of I ended up being this health tech expert because there were so few of us. So by 2007, I was doing a lot of M&A stuff. And so you just kind of had this trajectory where I kept getting into pieces that's now value-based care before knowing what it was. I personally was sick for a long time, and I started learning about what it was like to get around in wheelchairs and curb cuts. And I became really passionate about it. I thought it was a health issue. And of course, healthcare didn't want to talk about putting in $100 grab bar to save $3,000 a day times 18 for 65 plus, right? So I went to industry. Now we call it social determinant of health, right? But at the time I was working with the kitchen and bath industry. I personally, 7 years ago,
Sorry,
I
how did you connect the two? What was your pitch to the kitchen and bath industry? To like, where was the intersection with them and
yeah,
health?
no, it's a great question. So what I did was I made it about the baby boomer market. And I said, look, here's the 65 plus market.
Mm-hmm.
And if you don't start developing products and services to serve them, you're missing your largest profitable growth. And nobody wants to go into their house and be like, you're old and dying. Look at this really ugly grab bar and the plastic commode and all of the stuff that they would do from like the durable medical equipment. Like nobody wants that. Nobody elects for that. So when healthcare was not interested, I mean, here was my pitch to healthcare. My pitch to healthcare was, look, we put in $100 grab bar, 50% of all preventable rehospitalizations from a home accident or from a fall in the bathroom. If you cover that, then what you're saving is that when somebody 65 plus goes into the hospital from that fall, it's 18 days in the hospital, $3,000 a day, and 50% of the 65 plus will die within a year. And 50 after, because of that fall, that preventable bathroom fall, right? Well, that was my thinking.
And so, one second, who was the supposed, who was, when you were talking to the industry and saying create this product, and was it a D2C company or B2B? Like, were you saying go to healthcare, or were you saying go to the patient, so to speak?
Right. So healthcare was not interested, right?
Okay.
Because how do we pay for it? Why do we pay for it? And so I went to the National Association of Home Builders and KBIS, the Kitchen and Bath Industry Showcase, and Coverings, which is all the flooring, because you have all kinds of things once you go into this space, like wheel-in showers that are beautiful and ledges where people can sit down. And I mean, this is like a very dangerous place. And what I said was, look, here's the buying market, and I will teach you how to teach each other how to build and sell to that market.
Mm-hmm.
And they did. And we called it Aging in Place. That was not my name. And they set up certifications. And we did
So
trainings.
it was B2C. So
And
the people that were
now,
buying were the actual patient.
yes,
Okay.
they'll pay cash
Yep.
for something beautiful.
Yeah. Here's a 80% chance of not dying in the next year.
Right.
And all for $69.99. Talk about a commercial, right?
Right. And they got it from a financial perspective.
Yeah.
And now if you look, Moen and Delta and so many of these companies, they have beautiful items that you can put into your house and not feel like you're being told that you're sick and old, right? You're not walking into the plastic commode in your house. And really receptive. And you'll see that this is all still going on. Now they all do Aging in Place every single year. So I was getting sicker and sicker and sicker. No idea why.
Yeah, we didn't touch on that yet. So you just started feeling that way?
Because when I went to the last time I spoke was in a wheelchair. I was speaking on Aging in Place and universal design as an expert. I was already in a wheelchair.
Whoa. Okay.
So they didn't know what was wrong. And one weekend, Labor Day weekend, 7 years ago, I had to go into the hospital because I was like losing all kinds of abilities. I'm thinking, I'm in healthcare. It's Labor Day weekend. Staff doesn't want to be there. They'll get me in. They'll stabilize me. They'll send me home. Right? And I'm a single mom of 4 kids. Like there was nobody else there to take care of the kids, which matters in the story. So I'm there in the hospital and they said, oh, well, you know what? You're not safe to be home. You're not safe to take care of your kids at home. You're not safe to take care of yourself at home. So we're sending you here. They give me this piece of paper. And I'm looking at the paper. I'm like, it doesn't say anything on that paper about rehab or therapies or help, sort of all of the things you would expect if they were sending me to, say, like for post-acute rehab to
Mhm.
get better. I said, are you sending me to hospice? Well, like it's not really hospice. It's just, but there's no care there. Like, you don't even know what's wrong with me. So I'm like, I'm not going there. So they bring in a psychiatrist who sits with me for an hour to get me to, accept my situation, make videos, say goodbye to my kids, because they're already saying, I'm dying. Let's say goodbye to my kids without knowing what's wrong with me. I'm like, yeah, okay, thanks. Next. I choose not to do that. So they bring in security. 2 security officers in uniform with a wheelchair. Man, will you get in? I'm like, I will not. Like, make me, So I do like a lay-in at the hospital for 6 days. I just won't get out of the bed. And because I know there's a bed utilization person somewhere in the infrastructure that's not going to want me just sitting there, So 6 days later, they said, okay, we're going to send you somewhere else. My winning ticket was the basement of a 1-star skilled nursing facility, right? With mold dripping down from the ceiling, all concrete, bars on the window, right? Like it was not even a real room, right?
And I'm sorry.
Mold.
Let me just recap this for a second because I think we missed the first piece.
Because we're barely getting started.
You're living your life. You're living your life,
Right.
and you're doing this, aging in place thing, and then all of a sudden one day you start not feeling well. You start deteriorating quickly.
No, so I think it seems to me that it took several years,
Oh,
which
okay.
is like
But
like
over
it was
that
like,
course, you're checking in with your doctor, and no one knows what's wrong with you.
yes, I'm regularly seeing the doctor, and for example, I'm like, should we do a mammogram? Like, what? Oh no, you're too young, meaning you're too young to qualify for a
Yeah.
mammogram. Should we I had all kinds of wonky tests, but they couldn't figure out what was wrong with me. My organs started shutting down.
Oh my God. Next thing you
And
know, they're sending you to hospice. Wow. Okay. And how old are you at this time?
I am in my mid-40s, my
Wow.
early to mid-40s at the time. Yeah.
Okay. Sorry. So fast
And I
forward. So
have
you
4 kids. At the time, my
right.
children were age 9 to 17.
Wow.
Like
Okay.
some young ones,
Yeah.
right?
Okay, heavy story.
Okay.
So you get away you get away from the angel of death, so to speak, from hospice, but your big Garden of Eden is a 1-star assisted living in the basement with mold. Fun. Okay. Yeah.
So I'm there for a few weeks and I'm like, what have we not done? What have we not done? And I do a self-exam. I go back to that primary care doctor for the last time. And I'm like, I know you said I'm awfully young, but can you take a look at this? He's like, we should send you for a mammogram right now. So they send me right for 2 mammograms. They do 2 biopsies and they send me back to the nursing home. I get a call, the same 1-star nursing home with mold coming down from the ceiling. I wish I have saved all my old computer stuff with the hope that I can retrieve the pictures I took, right? To show that this is not a story. So, so I get a call from scheduling. Now, scheduling, it's not the doctors, not the nurses. It's the admin people who may live anywhere in the world who are scheduling appointments. And she says, I have amazing news. We got you in with a terrific oncologist tomorrow. I said, oncologist? You mean I have cancer? She says, nobody told you that you have aggressively metastasized ductal carcinoma? I'm like, nope. I get it from scheduling on a call while I'm in the nursing home in the wheelchair. So I go in the next day, right? I go in the next day and I have 3 people from oncology, a doctor, a nurse, and a social worker, 3 people from palliative, because remember, they believed I was dying, a doctor, a nurse, and social worker. I meet with all 6 of them the same day. And I said, look, here's the deal. I'm in healthcare. right? I'm not going to Google what you say. I'm not going to call my colleagues for a second opinion. I'm going to do whatever you tell me to do, but you need to know that I'm actually going to survive. And they're like, all right, like, they didn't believe it, right? But, and we then started 10 months of weekly chemotherapy. I had 5 rounds of chemotherapy. The last one was synthetic mustard gas. I became legally blind. I
As a side
lost my
effect.
teeth as a side effect.
Wow.
My teeth started falling out. This is all reconstruction.
Oh my
I was on liquid only nutrition, all in for almost 3 years. There is no good flavor at Boost, if you're wondering, after 3 years of not having real food. And they were just trying to shrink the tumors. I mean, they were in my lymph node system. They were going up like my brain, like the skull. And then during all of this, where were my kids? Right. So I sent one out of the country. I sent one out of state, but I had 2 in elementary school. And they were put into foster care because there's no solution in our system for a sick parent who doesn't have, a spouse or a sibling or something like that. And because there's no place in the system, the only way they can do it is by saying that sick parent is negligent. So I became legally negligent and under Child Protective Services supervision because I had cancer. And so while I'm doing all of this, like while I'm fighting my own battle, I'm having to go into court to try to see my own kids. And like it's all going on at the same time. So 10 months of that, the tumors all shrunk enough that a surgeon who was like super courageous was willing to operate. They were like just on the line of what was legally allowed in terms of size. And he's like, but you're not left-handed, right? I'm like, why, yes, I am. He's like, oh, because I don't think I can save your left arm. Because I'd lost so much vascular from the tumors and stuff that they just didn't think they were going to be able to save it from the surgery. So when I woke up after this first long surgery, I was like, my arm is here. Yay.
Wow.
And then all in, I had 50 surgeries.
50.
50. I had beyond maximum on radiation. So I had everything.
And you said this was a process of how many years?
This was all in the same year. So it was 10 months of chemotherapy. I was in the nursing home for about a year. And then I was able to get into kind of like middle ground housing, and then fight to get my kids back. And I got my kids back. And then we did like because I had lost so much vascular, we had to do, and I was rejecting everything. We had to do an internal transplant to take vascular from my stomach and put it up to my upper quadrant, which worked, only my stomach didn't close. So for 6 months, I had what's called undermining, which is you could put your arm in my stomach up to your elbow and wave it around. This I have pictures of the whole like open stomach. So one of my kids is home now, right? One's out of the country, one's in another state, one's still with foster care. They had hired lawyers to try to fight for me getting my kid back. And the youngest was 10 now. And we're there, and they said, you need like your IV changed. I was on an IV. I was eventually on a wound vac. I had a totally open wound. I was not mobile. And you don't get like home nursing unless you're cash pay. You don't get like somebody to come out every day. You don't get like, you kind of get like once a week. So you need like wound cleaning and IV changing. They said, we're going to have to send you back to the nursing home. And because you don't have a caregiver. And my 10-year-old said, I'll do it, mommy.
Wow.
And she ended up doing my debridements and my IVs because that's, so that I could stay home with her.
Wow.
So.
Wow. And what's she up to today?
She is going to be a senior in high school, and she wants to be a oncology nurse.
Wow. Wow.
Yeah.
What a
and my and my
Okay,
third who
take us through the good part, please.
so
Because
my
today you
third
look
so
tremendous and you're
thank you.
doing tons of things and your energy is through the roof and you look great. So
Thank
please bring us back here because
Thanks.
this is a
So
rough
I will just
story.
tell you that all four of those kids are rocking. They're rock stars now. The one
Okay.
who was put into foster care now is training to be a lawyer for foster
Amazing.
care children.
Amazing.
They're all doing amazingly well.
What a story.
So yeah,
That's some tough kids you have. Wow.
yeah.
Tremendous. Okay, so yeah, so you start
So
healing, hopefully.
so I'm healing. I'm getting better, and I'm ready to come back into work.
Wow.
And I just realized that I was more passionate about the work I do, not less. Meaning, people are like, I can't believe you came back into healthcare. I'm like, no, look at how much more I can help now that I understand things that you couldn't read in a book. And at this time, this was after the ACA models were coming out, and I started to understand that when we change the financials, when we can financially incentivize the business of healthcare to do the right thing. And that for me became like enormous mission. Like for me to go through everything I've gone through with this, I talk on stages as you talked about all the time. And I talk about everybody is a superpower, right? And so I say, like, you were born with a superpower. And then people lied and they let you down and you tried and you failed. And all of this stuff happened. And you kind of like we stuff it underneath the kind of grime of the life, but it's still there. So where is your superpower? Your superpower is at the intersection of your passions and everything that happened to you, all of your experiences and skills, right? Your story and what the world needs most from you. And where those two intersect is where your superpower is. And so for me, it was so clear that I had all of this from a lifetime in the business of healthcare, from this crazy personal experience that will never leave, to the fact that value-based care was really getting hotter and more available. And I saw that this was a place where I could match that passion and purpose with what the world needs from me. And I was doing a lot of startup stuff. I ended up being responsible for, over 50,000 beneficiaries. I became really I became very involved in the new models, what's now called ACO REACH. At the time, it was first DCE, and we had an LOI in for GEO. Then it was called GPTC. Now it's called ACO REACH. It's now kind of the foundation of where we're moving in value-based care. And now CMS, Centers for Medicaid and Medicare Services, says everybody's going to need to be in an accountable relationship by 2030. Which, if you think about this slow boat that healthcare is, right? There's with all these silos and everything like that, that's around the corner.
Yep.
And so about a year and a half ago, I had a business deal go south. And I said, what's next for me in terms of do I go stay in operations? And I said, we need an army of smart, passionate people to lead this because it's all going to value-based care. The question is, are we going to be good at it? Right? And so I realized that this phase, my place was to be able to empower other people to do it.
Yeah. I just a tremendous story, and wow, it's obvious why you're so great on stage because your energy is infectious, but you also have this crazy story. And to hear a story from someone like you, who thank God now is on the totally other side of it and being impactful, which there's so many lessons and points to be learned from the story. I mean, that doctor that just wrote you off and wanted to send you to hospice. I mean, look at what you're obviously accomplishing today. But let's just talk about the very specific value-based care contrast that you have here, because if you can guesstimate what your cost of care was between staying in the hospital for all those days, all those surgeries you went through, what was that cost? Hundreds of thousands? $1 million?
Certainly over $1 million.
Ridiculous.
50 surgeries. Three of those surgeries were over 11 hours. I mean,
and what did you and what really set it off was the mammogram, right? That's what set off the actual
which was denied tried because of cost control.
Right. So, and what does a mammogram cost?
I actually don't know that. I should know that.
Whatever,
It's
a
a good
couple
question.
$100,
Not a
maybe
lot.
$1,000, couple
Not a
thousand,
lot.
not even. Okay.
The other is also when you're looking at that, right? It's crazy. But when you're looking at that, because I couldn't get the care at home and I had this open, I got MRSA. I got C. diff. I got meaning all of these very expensive secondary that never would have happened if I was getting the kind of high touch, early intervention that we advocate for.
Yeah.
Or how did I get to my appointments?
Yep.
I was in an electric wheelchair, which is, I challenge you and anybody to spend an afternoon in a wheelchair.
I hope to not take you up on that challenge.
No, I'm saying, I don't mean a lifetime. I mean, to see what it's like.
Right.
And an electric wheelchair is so different. You can't put it into a vehicle. You can't just go on the bus if the bus isn't properly equipped, right? So I had to wait. And of course I didn't drive for 10 years because I was legally blind. And so.
1 second. You were legally blind for 10 years?
No, I was over the course of the 10 years, I did not drive.
Right.
Some of it was for the walking, and some of it was for it was all. So I can't tell you, I was in Minnesota at the time when I was sick. How many steps are involved in how do you get a special vehicle to come pick you up on time and get you in the snow, in many feet of snow? That's what it's like in Minnesota winters. From your house, from your home that's not accessible into the vehicle. And those are the kind of things that we're addressing with value-based care. We're saying, let's provide free transportation. And it's not just healthcare anymore, right? Both Uber and Lyft are in saying, let's get involved in this, right? So, so many of these pieces that I just couldn't have known by just reading case studies.
Yeah. Tremendous. So, all right. So you found your intersection of life experiences and what the world needs from you, right? And that was driving value-based care. Who has been? What have been some of your experiences from that point onward? Who did you approach? What kind of organizations did you go after? And how did you go about trying to start getting some more VBC models implemented across the country?
So here's the great thing. All of the experts are self-taught, which meaning because it's all very new, it's all very complicated. And so if you want to become an expert, it really just requires some time and focus because there's so much opportunity. What happened for me was, so it's so interesting. It started, I had a client who did sensors for remote monitoring. And and so I had to develop a reimbursement model for their pro formas for the money they were raising. And I didn't have anything to explain what a CPT code was or why CMS mattered in figuring out your pro formas to do pro formas for a sensor company, essentially. There was nothing that I could pull from. So I just started and it was so funny. I sent this client a message recently because he's like, could you just get me some slides, Gail? And literally, it sounds so silly, but that changed everything for me because I became this massive creator of slides and messaging of how to simplify this and learning myself the whole time. And so I've done a lot of work in startups over my career on sort of all sides. And I started kind of getting deeper and deeper in order to serve my startup clients. And then in 2020, I got a call asking if I knew what DISRIP was. And I'm from a large post-acute system in New York. And I'm like, I know what DISRIP is. They're like, amazing, you're an expert. Come in. We need to talk to you. Now, I knew what DISRIP was. That was about all, right? And all of a sudden, like a couple months later, I'm doing all of the value-based care planning for an organization that had 700,000 beneficiaries coming through, right? And I'm learning, and this was in the middle of COVID, right? When we're all learning. I mean, I was at so many of the announcements as New York was going into lockdown. DSRIP was ended in this whole sort of like unexpected battle between the executive branch and the governors. There was like, I just was in it very deeply. And at the time when I was serving this client, direct contracting came out. And I started learning about direct contracting entities so that I could encourage them to become one. And then we go into lockdown and everything's like crazy. And they, like 60% of everybody in healthcare, stopped doing value-based contracts during COVID, which I'm happy to talk about why I think that's so ridiculous.
Okay.
But
talk about why you think that's so ridiculous.
Okay, well, so why did hospitals have such financial trouble during COVID? They were full. It was not volume, right? When we talk about the sort of this move from value-based to value-based care from fee-for-service, we think there's like issues of volume, and because it was not volume. They were packed. It was because hospitals in particular rely on higher profit margin elective surgeries, and they were not doing elective surgeries. And they try to not have a lot of long-term, acute, expensive on the ventilators, right? So, but who was getting their money? People who were on capitated contracts.
Yes.
Right? Because those who were
important to point out to the listener, keep in mind the very things that you make the most money on in fee-for-service are the things you lose the most money on in value-based care. And the things that you lose the most money on in fee-for-service are the things that you make the most money on in value-based care. So if your fee-for-service hospital is losing money because all their elective surgeries are gone, which is where they make all their money, but they're just packed with basically the low reimbursed things, flip that on its head and you have a very profitable model.
Yes, exactly. So why did 60% of all health systems get out of their value-based models in the middle of this? Because with the complexity, most people who are making the decisions about value-based care do not actually understand it. They just don't. Every single meeting I have, I start with, I know you know this, but... And then I I don't know if you've heard my whole thing with like the broken arm and so my very basic way of explaining the difference between, this is a Gail Zahtzism, the difference between fee-for-service and value-based care to health equity. So here's fee-for-service. You're walking on the sidewalk's broken. You trip, you fall, you break your arm. You go to the hospital, and just like the mechanic, they give you a bill to fix the arm, to diagnose it, to scan it, to set it, right? Then you go home, you pay a bill for a fee for physical therapy. I call it a fee for sickness because they're only getting paid when you're sick. So there's no incentive. There's absolutely zero incentive for them to fix the sidewalk.
Yep.
Right? Mm-hmm. Value-based care says, we're going to pay you the same amount whether the person comes in or not.
Yeah.
So what happens? Now you're financially incentivized to fix that sidewalk because now you're going to make more money if I don't come in with a broken arm than if I do come in with a broken arm. And health equity says there needs to be that safe sidewalk in every single neighborhood, regardless of race or economic status. And so I've been giving this over, I don't know, for a few years now. And all kinds of pieces like it. Like we throw out all these terms, right? Your benchmark, your DRGs, your prospective payment system, your quality measures, your minimal risk score, your like, and here's what I think most people do. They're like, yeah, I'm right on that. Like nobody wants to admit that they don't really understand what you're talking about because who's usually running value-based care? So and this is sort of like how I explain the person. I call him Joe. And Joe's been with the pay provider organization for 15 years. He's been a good soldier, and he's just going along doing whatever he's been told, kind of like upper middle management. And the pay provider in their contracting department put in all of these contracts to the government, whatever. And lo and behold, they were awarded a model from CMMI, Centers for Medicare and Medicaid Innovation. And now they're responsible for 20, 30, 40,000 beneficiaries. Like, wow, guess we should do something about it. Who are we going to have run it? Right? And the CEO says, Joe's been a good soldier. We'll promote him. And Joe gets the title, President, Vice President of Value-Based Contracting, ACO, whatever the title is. And Joe's only worried about two things, the Christmas party and the board meeting. Because at one of those two things, the same CEO or member of the board can pull him aside and say, my neighbor just went bankrupt from their ACO. The headlines just came out. I heard that there's a price change or whatever. Are we okay? And Joe just wants to say, we've got this. We're fine, right? And so a lot of my work is educating the Joes of the world. So that, because how do you make the best complicated decisions? You know, I liked you did this post the other day on AI and value-based care. And what I like about it is that you talked about the fact that it's really a data play.
Yeah.
Right? Yep. And success in value-based care is heavily about behind the scenes stuff. Like, everybody wants to solve to outcomes in 5 years, which is great, right? The triple aim of value-based care: lower the total cost of care, improve the outcomes of a population, improve the patient experience, right? But almost no one who's making financial decisions today has any financial reason to care about whether or not you're healthy in 5 years, because they don't know if you're ever going to be their beneficiary, right? So how do they make their decisions? Like, what, and how do they save the money? So, like, I have a client whose organization didn't get shared savings on an MSSP, Medicare Shared Savings Program. And I said, you know what? I think it's administrative. I think these are good docs. I think you're doing fine. They're like, no. It's all about like the decision making and the referrals to the specialists, the high performing specialists. I'm like, let me take a look. And at the end of the day, they didn't get their shared savings, which would have been half of like $1.3 million, like a lot of money, because of the risk corridor mistake they had made in an application. Right? But I'll give you another example of that. So this post-acute and sort of where I got really hot and heavy into the sort of like shared savings and the relationship between payer and provider. I saw a bunch of emails come in from Optum. And they're like, you're not getting your shared savings. You're not getting shared savings. They send these emails out patient by patient. So it was like thousands of emails that were coming in. I'm like, let me look into this. There's got to be. So it was for one facility, which is small in a healthcare organization. Like a post-acute facilities is small.
Yeah.
And every report at the end of the day said that they were not getting the shared savings for failure to give flu shots. I'm like, no. Yeah. I'm like, no. We're talking about a post-acute facility. I know everybody's getting a flu shot, right? Because one thing they do is they go around with the like flu, and everybody gets a flu shot. Like, it's just. So I brought in clinical. I'm like, they're saying you didn't give flu shots? They're like, of course we gave flu shots. I'm like, did you report it? Of course we did. It went into the tech system. So I pulled the tech team in. I'm like, so funny thing, like, we're not showing these reports happen. They're like, of course they happened. We're just like the tech team. If the report came in, it went out. Well, long story short, a lot of teams by the end of the day, those reports had never gone to Optum. And that organization lost over $2 million in 1 quarter.
Oh, my goodness. Right?
And so this is the stuff that scares people. So they say, we're not going to do anything about it because this is like, we understand heads in a bed. We don't understand how to do risk stratification, right? And part of why I'm so dedicated to trying to teach other people so that we can do this. The thing is that CMS is saying it doesn't matter, right? We're going this way, so you better figure it out.
Up on the train.
And I think that, right? And even more telling than their strategic commitment to 2030, I think, is what happened to physician pay this year in 2023. Becker's reported that your physicians in the US this year received, when you add everything up, a 20% pay cut. 20%. So every doctor, when you average it all out in the US, is making 20% less in 23 than they made in 22. And I know that there's like this kind of like constant, this like belief that, oh, the doctors are just making so much money, they can spare it.
They're
But
not.
a primary care doctor who we rely on completely to make this system work
Yep.
makes far less than an entry level person doing most other things, certainly far less than anybody with a similar number of years of skill.
Yeah.
Like just far less. So, and then when you add in liability insurance and everything else, there's just, and like another piece that I think people are missing is that you can pay doctors more in value-based care, right? And I think it's a big warning that I give to my clients and people that I speak to. It's like, don't go for the easy pay cut. Like, it doesn't benefit you at all because you end up with a revolving door of attributed doctors. There's no buy-in. There's no like partnership because you've already come in and been like, this is going to be a negative relationship because I'm saying, hi, I'm Gail. You need to take a haircut. Like, right? Like, okay, now let's get some good work done together. Like, whereas if you look, primary care is 4 to 6% of the total cost of care. Okay, that's say $4 for every $100.
That's crazy.
Right? Acute hospital is over 30%.
Oh my goodness.
Skilled nursing facilities, which the minority of people go to, meaning most people don't go to a skilled nursing facility, is over 20% of the total cost of care.
Wow.
Right? Like 50% of the cost of care happens in the last year of life. Like, I'm throwing these numbers out to say, why do we keep pointing to the primary care doctor who we don't have enough of and we totally need when if you're being smart about value-based care and how to administer it, you say, look, I can pay them 7%, 8% if they bring down my skilled nursing facilities or my 3% of care, that cost of care that happens just from infusion drugs. So a primary care doctor is almost the same cost as infusion drugs.
So maybe I'm not understanding this correctly, but doesn't that calculation only work when the same system owns both? Otherwise, how are you compensating for one with the other? Like, if you're disconnected and you're an independent doc over here and you're an independent skilled nursing facility here, then my saving money here doesn't affect you here, right? Because you're not part of the same pot.
But if you're in a model together, so let's say you're in an ACO REACH, and in an ACO REACH, the ACO REACH organization is receiving a per member per month, a partial capitation against the total cost of care. So they are financially incentivized to lower the total cost of care because that's how they're going to make money.
Yep.
That intermediary, instead of going to you, primary care doc, and being like, oh, you got to take a haircut, instead could get people on their team who really understand how powerful working with the numbers can be.
Yep.
Right? And what's possible, and show how you could pay your docs way more. Like we need a lot of people to really understand this, which is why I'm super committed to this, because we're all going to value-based care. That's a foregone conclusion. The question is, are we going to do it and end up with profitable organizations? Are we going to do it with healthier communities? Are we going to do it with happier patient experience? Or are we just going to take the same kind of broken way we've been addressing fee for sickness and say and do the same thing, even though we're getting paid differently?
So you're proposing to I'm not sure who this goes to, but you're proposing basically that make sure that balanced ends of the healthcare spectrum and continuum are in the same pots. So if you call the pot an ACO, make sure that you have primary care members and skilled nursing facility members and infusion members, and so that this way you can work to balance the entirety of your little picture, and then that will bubble itself out so that the country will balance out. Is that what you're proposing?
Yeah. So yes, I'm a big believer in owning or being accountable or responsible for the total continuum of care. A big believer. And there's counterintuitive pieces where there are parts of that mix that your typical pay provider is afraid of. Only if they would learn how to do that, it's where they could make their most money and have the best outcomes. The example that I'll give you is dual eligibles. So a dual eligible is somebody who is eligible for Medicare and Medicaid.
Yep.
So what do we know? That means they're 65 plus or permanently disabled
Or
and
many.
poor.
Yeah.
Poor, right? Okay. Now, of all of the people on Medicare in the US, less than 20% are dual eligible.
Okay.
Meaning less than 1 in 5 meet that criteria. 38% of all of the cost of what Medicare does is specifically for those dual eligibles. So a dual eligible costs the healthcare system twice as much to take care of. So why? Are you wondering why?
Well,
or are you just amazed by the numbers?
Well, my initial thought is that would make sense to an extent because they're duly insured by the same organization, no? So you're paying on
it's
both sides.
costing, meaning, so I call dual eligibles the health nomads.
Okay.
Because it makes sense to me visually. Meaning they don't have a primary care doctor. They don't have a regular clinic they go to. Instead, they go to the ER 10 times a year, right? They have the same tests done because they go to the ER. They're like, the doctor says, go have an x-ray on that arm. And the patient says, I just had one yesterday at this other hospital. And the doctor goes on and tries to pull it, but because of our broken HIE systems, can't pull it. And what does the doctor do? He says, I can't pull it, order another one. It's not even the doctor's fault or the patient's fault, right? Meaning it's like,
now why is that an outcome of being duly insured? Why is the outcome that the patient just goes to the ER and doesn't go to a doctor?
So what we have found absolutely conclusively is that the dual eligibles tend to not have an ongoing relationship. So why? They don't have a home. They are transient. They don't have like any kind of stability. How do you find a primary care doctor who only takes like sliding scale? Like, meaning you're eligible for Medicare, Medicaid, but they're generally not receiving both, right? So they're generally just like maybe receiving one of them. It's that their ongoing kind of care does not get that kind of consistency that you have if you have, look, I've seen this other side. When you are only struggling to put food in your stomach, you don't have a table to put it on, and you don't have a home, and you're moving around, like, how could you possibly, without having the stability of everything else in your life, develop stable healthcare relationships?
But how do we fix for that?
So, so first of all, CMS is paying a lot more money to the intermediaries to address this, which is why I say, look, if you're only in this for the money, that's fine. Like, I'm not judging like one way or another. If you're only in this for the money, pay attention to the dual eligibles, because you will get so much more per month that you can do way more care for them. So the kind of things that you're doing, interventions, chronic care management, remote monitoring, going into the home, like having care coaches. These are all the sort of things that work, like that work for this population if they're being offered, right? Well, if you're getting more money because now you have a higher risk pool, because you've got a more expensive population, you're getting more money than it would cost you proportionately. So if you're smart, you invest in these sort of pieces that are health system without walls. You have somebody calling all the time. You have that person being able to do something about it. You send somebody to the house, because once you're no longer doing fee for sickness, once you're no longer requiring somebody to come into the clinic, you can treat them wherever you want. You can do a meetup at Starbucks. You can answer a text. You can answer a phone call. You can talk to an approved caregiver. Like, the thing is, you have to set it up. You have to do it. Right. But if you're doing all of that, you end up spending far less than how much more you get in profit.
Yeah, I think though, when it comes down to patients of that population, the one thing, I think the biggest challenge, probably, I'd love to hear your thoughts on this, the biggest challenge is going to be their phone number. Because if they're transient or they're homeless, you need one consistent way to get in touch with the patient. And there's a lot of patients of that demographic that they can't afford their phone bill. And so they're continuously getting new phones and new numbers. I don't know how you fix for that.
So first of all, you can give them a phone, which ends up being much cheaper.
That's true.
Right?
That's true.
Like,
Yeah.
I mean, we've given people, huh?
Yeah, that fixes the problem. Yeah.
Right. And the other is, you can connect them. Almost all social service organizations have a deal with people who are receiving DSS services, where you can get like a very inexpensive, like I pay over $100 a month per line for my iPhones and everything like that. But they have where you can get them for like $20. You also can set up phone stations at shelters and other places where people can receive their calls and be allowed to make calls back. We've set up computers at places. They've been bolted down, but like at anything from like libraries to health centers to, frankly, food pantries. So start making, since the access can happen anywhere, let's prioritize giving access.
Yeah.
Right?
Yeah. Wow, this hour has gone by tremendously quickly, and I suspect that this won't be our last conversation. But we are coming up on time, and it's definitely a lot to think about. I think it's very obvious, like I said earlier, why you're so successful on stage. And to all our listeners, if you're looking for Gail, it's gailzahtz.com, GAILZAHTZ.com, correct? And you'll find her speaking engagements. Gail speaks for, besides for consulting to ACOs and various organizations, Gail speaks really, really well at huge conferences, thousands of people packed into rooms. And so, Gail, it's tremendous to speak to you. I think you really are one of the you have a really, really good understanding of value-based care, which I think is rare. So it's wonderful to speak to you. And
thank you for having me. This is great.